Ladies and gentlemen, I wanted to thank you all for coming today, but I understand the draw of coming back to visit at an originating place of your basic preparation, and then also to see what are good memories for most of us of our undergraduate education. They remain with us. Trust me, when you get to be my age, they are still there. So I'm delighted to see all of you. Hello.
I know you are.
And we'll go ahead and start. Our topic is basically nursing in today's healthcare reality. And I took a few minutes, maybe 20, 30, to prepare this, so that we could get a chance to see from a perspective, not the only perspective, but a perspective, about what it means to be in today's healthcare reality as nurses. And so I've decided that we needed to look at cultural influences and the technology as one of the three major, and then we're going to look at essentially the challenges and opportunities. Again, I don't claim to have the perspective of the whole world of nursing on this, but I will give you the perspective that I've gleaned from both my own experience and what I could find in a lot of the literature today that's telling us what that opportunity and challenges are all about. And so, one of the biggest is cultural influences, and that represents population changes, communication, language, and literacy, and the multicultural values and the influence of all of that on the roles that we play in nursing. And it speaks to really adaptation of both care providers and care recipients. And make no mistake about that. It is an ultimate reality for those who will do their jobs on both ends of those roles. And if they do it well and understand it, it will be to the benefit of everyone, the profession and the patient population. So cultural. One of the things you need to know, because we suggested that this was a changing reality, and I'm going to suggest that the population changes reflect the census for the United States for the past 10 or 15 years, actually confirms that the society during that period has reflected increasing evolution of our multicultural realities, okay? National statistics tell us that the census is 321.4 million, and that's not the most recent because you don't usually get them for about a year or two after, but that's what it was recorded in 2015. The immigrant numbers, and let me explain to you a definition to guide you for the immigrant. The immigrant population, by definition, includes foreign-born and immigrants. They are considered interchangeable. And they refer to persons who are not U.S.-born and who have don't have U.S. citizenship at birth, all right? And that includes lawful and permanent residents, naturalized citizens, refugees and asylees, those who come to us in a refugee capacity, and those who are seeking asylum, but on a more voluntary nature. I think it's important we understand the distinction. Refugees come usually as a consequence of running away from something. So there's a whole issue of choice in that process. Asylum is also something that one is seeking relief from, but I don't believe it has the same urgency. And in today's world, I guess the only best thing I can describe is just look at what's happening in places like Syria, in Africa, in which people's lives have turned into utter and pure disasters. And so they're seeking to get out, okay? And then those on certain temporary visas. There's a category of visa, which is the H-1B, which are those classifications for desired immigrant populations. They don't come for citizenship necessarily, although some of them will get it. But they're in a specialized category because they have unique contributions to make in the area of science, technology. And so they represent a fair number, and a lot of the impetus to retain that classification, by the way, in case you ever do any reading, is from the corporations and the industries that need them and want them, who feel that they're not finding the necessary numbers from our existing American graduate population. Just an interesting point. Okay, and so for those people, We had 43.3 million numbers in this population. Out of our total population, they represent 43.3. And in 2015, and that's 13.5% of the population, by the way, the 5 largest representations of foreign-born were from Mexico, India, China, including Hong Kong, and the Philippines. Now, in the one-year period where there were some changes, you'll see that it's a state of dynamic flux. And so in the years 2014 to 2015, the recent immigrant arrivals arrived from a different order. It was, number one was India, and then China, and then Mexico, and the Philippines and Canada. Any questions of Canada? Okay. The dynamics of that happen to be that many people will first go to Canada, and then they will seek immigration to this country or entry into this country. And there are other, but New Jersey statistics, just so we get a sense of how that national picture changes or influences New Jersey. We're among the 5 top states with an immigrant population, 5 out of the whole country. The others happen to be Texas and California. And interestingly enough, I think Arizona is somewhere in there, okay? English is spoken by the largest number of people in this country of all categories of speech, but it is the dominant, still remains the dominant language. 30.4% of the population aged 55 and over in 2013 spoke English and another language. I'm not talking about proficiency, I'm just saying they spoke 2 languages. And in 2012, more than 160,000 Muslim religious-oriented adherents were in our country, and non-English speaking correlates pretty positively with decreased education. So, moving on to the next piece of this picture is communication, language, and literacy, because they have significant implications in healthcare, both for you and for the care recipients. Among the issues that must be addressed with a growing immigrant population is that of English language competency, and the following will just elucidate that a little. They need English. One needs English in this country for transportation information, for travel directions, for assistance from governmental agencies, for adapting to the environments in which mostly English speakers predominate as the other cultural group, and protection and safety in circumstances in which their unfamiliarity with English in both the written and spoken form puts them at a singular risk of harm. For example, in areas regarding financial, personal, legal, and healthcare situations, which, as healthcare professionals, we have a unique responsibility to examine and then address. Since effective communication, as you and I all know and learned quickly, in the nurse-patient or nurse-patient-client relationship is challenging enough and not always successful, when it's conducted in English to English. How learning barriers then get magnified by a percentage of probably 400 when it's trying to conduct those interactions from English and English speakers who don't speak other languages to those who speak only another language. Over 20 million people in the United States are not proficient in English. And it may be inconvenient and frustrating when you're ordering food, but in healthcare settings, it can result in both delayed or inadequate care, or perhaps even result in a fatal outcome. Between 2000 and 2013, non-Hispanic whites, this is a Pew Research Center report, became minority populations in 97 counties in this country. And it is projected that by 2021, approximately 50% of newly insured will be less likely to speak English. Now that's under provisions within the Affordable Care Act, which has allowed for increasing numbers of groups to be insured, okay? That doesn't mean it's going to automatically make that happen, but anyway, healthcare recipients who are LEP, and that's a term you might become familiar with, limited English proficiency, okay? Limited English proficiency. So people who are recipients of healthcare in that category are at higher risk for adverse events than those who speak English, including physical harm, 49% as opposed to 29% for English speakers, and they have larger and longer hospital stays if professional interpreters are not used at admission and discharge times. They have greater risk for IV line infections and surgical infections, for falls, and for pressure ulcers. They have a greater chance of readmissions for some chronic diseases because of difficulty understanding self-management instructions. And that goes back to, what do you think we always tell people? The nurse always says, discharge planning starts at admission. Okay? And that obviously is influenced by the patient's diagnosis and a whole bunch of other things. But it means that even before we had this huge population of immigrants that didn't have fluency in English, we're trying to tell all of you who are English speakers, and we're dealing with English-speaking populations mostly way back when I started here. That was considering that we were dealing with English-to-English interactions. Now, imagine what that means. If you don't do the proper admission information and you don't prepare for discharge instruction as soon as they get there. Okay, so outcomes of healthcare experiences for the LEP individuals with primarily English-speaking providers vary from emergency situations related to both acute and acute medical, meaning physical situations, and mental ones. Those episodes that increase the risk of death or harm will require learning for short-term interactions, and that's a very significant area of risk. Huge. If you don't get the right information in the ER, if you don't get the right information as you're proceeding to get that patient through the hospital environment, and if we also don't manage to get these instructions very clear for patients who will have to adapt and respond to chronic illness roles and accompanying challenges with that, those are going to be disasters. To achieve successful healthcare outcomes, remember that LEP individuals and families require verbal and written assistance in the form of interpreters, and that's a very special category, interpreters in their language for verbal communication. And we'll talk about how that happens in a couple of minutes. And translation. They are not the same thing. Interpretation and translation are not the same thing. Translation is the written form by which you proceed to provide the individual with whatever information you deemed essential for them to know. But remember, translation, because it's written, requires you establish literacy. You can give me a piece of paper, as has often happened in hospital situations, where the agency and the emergency room all thought they had the answer to a lot of these problems. And they gave the patient, or pulled up on their iPad or their iPhone, I speak. And the options were endless. And the I speak was translated into, if they couldn't read, You're whistling in the wind. Okay, so nurse administrators will also note that the safety risks that accrue to the LAP care patient are automatically extended to the organizational risk. And limiting and decreasing that risk for both entities is best assured when quality health planning suggests or engages care recipients' comprehension of their medical condition. Treatment plans and instructions are understood, and that is established. And especially during care transition processes, complications and continuity of care require that they have access to such help. And the accuracy of the medical record needs to be assured. Medication reconciliation needs to be assured. Informed consent is not an incidental issue for the LEP patient. In fact, it can be the basis for a huge amount of management risk problems. And preparation for testing and procedures will also be needed if the agency and the institution and the setting is going to reduce their risk management, their risk potential. Our increasingly multicultural society will require ongoing efforts to promote the goals of integration and stability of the many populations, that together are to become the emerging and evolving American people. When healthcare providers, physicians, nurses, and other team members recognize and develop plans of care that respect the language, beliefs, values, customs, and practices of the well-established as well as the most recently arrived members of our society, we increase the likelihood for positive health outcomes for the recipients who seek our care. Positive health outcomes, both physical and mental, reflect one's adaptation or ability to respond adaptively to inevitable changing life events. It occurs when the interactions between care recipients and care providers promote and enhance increased capacity to thrive, to evolve during these periods of transactions and transition. That is not an incidental process, but it is the only overriding goal that you need to continue to think about. You may be in agencies and situations and settings that have a very low percentage of this LEP category. And that's important, and you deal with that with less obligation than those who are in those situations, such as urban populations, large medical centers, inner city situations, in which the data show that is where you're going to find your LEP populations. And what you should do about that will depend on how well you organize and coordinate with all of your administrative and levels of nursing. And you need to understand that there is a way of managing that and collecting data that will give you an understanding of who your population is and what are the language needs for the staff and what are the ways you will obtain that proficiency, or at least obtain the necessary communication skill for ongoing care, but also to provide for professional interpretation at those critical points. All right. So now I'm going to ask you if we could, do we have those questionnaires by any chance? They're in your packet already. Could you take a minute? Now, you need to know, this is not going to determine your continuing education units. Not at all. All it is a little initial survey that I would be fascinated to see. And if you can't answer beyond question 2, it's okay with me. But if you can go beyond question 2, please do. And then just pass them to your left, my right, so that at the end of the row, we'll have all of them collected. Thank all of you. We should get going, so we're not here and you got to do that, get those itchy things and those behaviors that suggest you're bored. Okay, so we'll move on, and the next thing we're going to talk about is one of the influences, a very significant one. Oh, I have it. Whoops, good. Okay. The other very major influence, obviously, is technology. I mean, duh, is that a new phenomenon? No, it's been around for a very long time. However, the technology evolution is both a continuing presence in the healthcare environment and an ongoing and more rapidly developing one. In fact, there's a great book, I'm sure you have other books to read, but one that puts a perspective is one by Thomas Friedman that just came out. The title is Thank You for Being Late. And it's an intriguing read, but what he does is he says, the technology that you're seeing today is the result of a confluence of events that occurred in 2007 as a result of all of the advances that were preceding that. But one of the biggest things he talks about is the microchip, and how between that and the social media data and platforms, Facebook, et cetera, you know, Facebook, for those of you who are very young, was not available except at institutions. It was not a general public phenomenon. It did not exist for the general public until probably 2006 or 7. Okay? It was in academic institutions and in other controlled settings. It was not there for the world to chat on, which is what they've done for now the rest of their entire lives. They've reduced whatever the time they're spending for reflection. It's now gone into chatting. Okay, the point is that in 1971, that book, if you have a chance, take it from the library or something. It will be there probably after a while. But it's good. It has a lot of good information. But he speaks to the fact that in 1971, when we had our first class of graduates at William Paterson University from nursing, okay? 70, right, 70 was the first. I'm so sorry. A year after the first class. Thank you very much. You're right. That coincided with the microchip being finally really available. But in every succeeding 2 years, it doubled its power capacity. And that ultimately became known and has been translated into a very formalized thing that's called Moore's Law. And Moore's Law basically shows you by that change in the microchip development, you compare it with the first generation, 1971, to today's microchip, and you will see today's microchip has 3,500 times more performance capacity. It's 90,000 times, more efficient, energy efficient, big factor, and it's about 60,000 times lower in cost. Those combinations is what brought us to today. All right? The phenomenal increase in microchip power enabled present computer electronics to collect, store, retrieve, analyze data. And massive data, not just some data, but massive sets of data in ever shorter time periods. And so along with wireless technology, and these advances, we now have enabled the overcoming of distance and time barriers. And so we have things like the cloud, and we have immediacy. And the technology pervades and has altered the many services and functions of society and has impacted, some would say reconfigured, all aspects of healthcare, including the following: diagnosis, treatment, delivery systems, and settings, all of which have affected at some level the care that you are providing in conjunction with the rest of the healthcare team. A few examples, just a few, because I don't want to keep us. DNA sequencing and manipulation has enabled gene editing and alteration that can prevent the development of a disease or treat one that has already existed. It can develop, the development of synthetic cells was based on this massive data collection that allowed them to engage in the presence of those cells for disease diagnosis and for repair and replacement of diseases. Use of stem cells, again as a part of this electronic capacity, to replace disease cells now exist for actual diseases such as, and is in clinical practice, for macular degeneration, one of the most common diseases that affect the elderly, and neurodegenerative diseases, Parkinson's, cardiomyopathies. All of these are now creating possibilities for, if not reversing, at least halting the advances in the cellular breakdown in those areas of the body. It speaks to the fact that, we might even someday, because they're talking about building body parts now, I don't know, maybe you'll get a tag that says original, or you'll get one that says synthesized. But the point is, there is a projection that we will now, not, I don't think, certainly not my lifetime, people will be living to 120. Well, I wouldn't ever want to be a 120-year-old associate professor anywhere. But the point is, to live to 120, if you had a life experience that was rich and fulfilling and still gave joy, probably has advantages. Immunotherapy is another example, where we're treating malignancies now in the replacement of chemotherapy, sometimes even replacing the need for surgery, which for the cancer patient, whose half of their lives sometimes can be devoted to enduring the consequences of either chemotherapy or sometimes surgical procedures, has been made better. Robotic surgery, excellent example. It multiplies to multiple body parts, including hearts and lungs and joints. It is unbelievable. And it's shortening patient days, which is a direct effect on nursing practice, and is shortening the complications because recovery is so different. One of the major consequences of any surgery, as you all remember, is the trauma associated. So if you are under somebody's guidance under a surgical procedure for 16 hours, a little exaggeration, can you imagine the degree of inflammation that would have produced and did produce? So the complications after surgery had much more to do with the body's need to repair itself from the damage that was done as a result of the surgical procedure. Robotics and robotic surgery has changed that enormously. And also delivery trends have clearly been impacted by technology. Computer chips make the delivery of supplies, equipment, to rural areas, to isolated communities, to health clinics that would have to sometimes wait days and during periods of loss of access would get no care or no supplies or no equipment. Most recent example is in one of my journals I just saw where it was under a specialized study, but in the Appalachian area, in Virginia, actually, southern Virginia, they have one of those remote medical areas designations, and they use the robot for delivering supplies. Now, it's an incredible idea. Think of all the diabetics who can't get because they don't have a local pharmacy. Think of those who have no resources and sometimes would go without, and now all you have to do is provide for and get some authorization from someone to deliver this. The implications are huge for that capacity. I think nursing care is a huge area because we are not untouched by the impact. I'll just talk about a couple of things. The assessment tools and apps that are available for point-of-care evaluation or assessment. Very real. The collection of patient data, labs, vital signs, and the receipt and transfer of information back and forth within the hospital and within the healthcare setting is now quite unreal. And very helpful in terms of better judgments for the patient and monitoring what's happening to their in their status. Communication via smartphones at the bedside of nurses, between the nurse, the physician, other departments, with LEP individuals, those interpreter services can be obtained on some programs that are now involved and available on personal phones. Most of the phones that are used in the hospital setting are obviously for privacy reasons, protected and have limitations and don't go out to other sources. But this implication is huge. Besides, there are instrumental, well, networks, I will call them, that are available. LAN, and there's another one by 4 or 5 other companies. You can go online and note them. New Jersey Hospital Association has a network that has now arranged to have hospitals who wish to use that network for interpretive services can sign up within the New Jersey Hospital Association. Don't ask me about price. But what's important is the return on investment for those who are in administration shows that there are significant returns on the investment in short periods of time by an improved quality outcomes, an improved care, improvements in the areas in which they're being measured, because you know that reimbursement is now tied in very much with outcomes. And so when patient feedback, which is a 30%, I believe, configuration in how they determine that for your grade. When that is enriched and improved with this kind of interpretive service, it's not incidental, even though the initial outlay may be quite costly. Okay, so practice environments, let's just speak about that. The automated medication systems, most of you are familiar with, correlation with patient ID and current orders is very helpful in terms of safety. And clinical decision-making has been enriched. Clinical decision systems. Oh. I pulled off the little buffering system. Okay. Provide access. Those clinical decision supports in the forms that they come, provide access to changing information, treatment alerts, information about compliance with standards and the current standard of care, and related to patient diagnosis. Robots for transporting lab specimens and for delivery of patient supplies and medications, all time savers for the nurses' staff. And a variety of devices and systems provide for, as I said, the interpretation and the translation. It would be imprudent to ignore the ethical issues accompanying increased uses of technology, and awareness will enable protection and correction. 2 examples is all I'm going to give you. But do you remember when they had the cyber extortion situation in, I think it was California? And basically, the cyber extortion of the hospital, after they hijacked the entire patient communication network. So the patient network in the hospital was hijacked, hacked. The hospital could not function in ways that it had totally geared itself to function. And the extortion, which I think is the evilest part of it, personal commentary, was that they were paid off in bitcoins, so it could not be traced. So the entrepreneurs that are out there in both the good and the bad. But the reality is that institution paid thousands of dollars to have their system network restored. And so now, let's hope, someone is working real hard to make sure that that can't be done again, and that they will share that information with other system networks in other settings. But that's a reality that comes with increasing the possibility of the extraction of information by others than for it's intended. The compromise of privacy rights and protection of patient data, prohibition and prevention of sharing patient information as images of patients or info about patients deriving from any source other than the patient themselves needs to be guaranteed, and we need to be increasingly aware. There was a terrible incident with student nurses, I guess unknowingly, I want to believe unknowingly, in a rotation in a maternity and delivery situation, took pictures on their iPhones. Now, was it malicious? Not at all. But it was outrageous to think that we failed so badly to incorporate the implications of the technology for their current understanding of the ethical code. I mean, patient privacy is the cornerstone. Autonomy of the patient is the cornerstone. Now, the point is, it was not malicious and it was stopped immediately. But it was a lesson to be learned that says we need to understand how the technology can be so good, but can also really subvert some of the other goals that we have in healthcare. Okay, and then finally, that autonomy. The availability of advancing technology requires that patients remain central to the decision-making process regarding treatment. They can still refuse care. And the more important that is now is because with an LEP population, it doesn't take many incidents to understand how pervasive and threatening that may be. When you hear about the numbers of patients in emergency rooms and other places that signed consents to have things done and to them that they really, in retrospect, never understood. Okay? Heads up. We are now moving on to the challenges. Don't you love the way that just goes? Okay, so the challenges and opportunities of the profession. I will not dwell on this too heavily, but I will include things like the RN job growth rate, predicted for 2012 to 2022. It's an ANA source that gave us this. 14 states expect to have a 20% increase in growth in job opportunities. 30 states, 15%. 10 states are expected to account for half of the job growth. And those states happen to be Texas, California, Florida, Pennsylvania, New York, Ohio, North Carolina, Illinois, Michigan, and Massachusetts. Now, if you want to go online, and you can look up all of those statistics, and I bet you'll find that also happens to be one of the several of the areas and regions of the body where you have a huge influx of an LEP population. So it ties in with the connection we made before on the influences from culture. The growth and replacement includes RNs and APNs. This data refers to just RNs and LPNs, not LVNs and not LPNs. And employment will increase from 2.8 million. It did increase, rather, from 2.8 million to 3.44. That's a 20.2% increase just in the last, I believe that data was for 7 years. Projected number of new jobs, 574,000. That's what's going to be projected as new jobs available. But that also has to account for the fact that some of that is going to be as a result of retiring nurses and nurses who have left the profession for a variety of reasons, including the fact that maybe their economic status changed, and so in a period in which the economy then changed back, they may be more willing to leave because some of them are more mature nurses. However, remember, institutions loved the number of nurses that were staying who had experience, who provided guidance for new nurses, who really provided for a really quality environment. So you need to understand the implications of that in terms of what may happen when there are no more or very few, and we need to watch how that progression proceeds in terms of percentages, because you could reach a point where the care environment may really lack enough experienced people. Okay. The other thing that is in that projection of APRNs included in the RN projection is that It includes the reality of replacing MDs who in larger and larger numbers, or fewer and fewer, are going into general practice. And so it almost seems that one could sit down and have fun with predicting what might be going to happen in, say, another 10 years, where there will be an absolute shift in the levels of care delivery that will say anything related to primary care that has nothing to do with specialty care will be done by APNs. And that the medical profession will increasingly become more specialized. Now, again, that will create the need for understanding the dynamics of retirement of those currently in general practice, et cetera, et cetera. Please don't tell the AMA I'm saying this, but what I'm simply implying is it could happen. And more and more interest in specialties seems to be evolving within the medical profession, so it does create the possibility to imagine. However, the leading, no, we don't need to do that. Okay, those are the projections in terms of job. Education, I need to tell us briefly, it's clear that a continuing need for education by those in the profession is going to promote better health outcomes for both populations that are both English-speaking, but also for those who are the newer immigrants to this country. 55% of nurses are currently BSN graduates, or have a baccalaureate, I shouldn't say BSN graduate, have baccalaureate degrees. The hospitals show preferences for BSN nurses, and that's related to a lot of the studies that have indicated and show preference because they produce quality of patient care increases and desire for magnet status, which incorporates the percentage of BS graduates on your nursing staff. And so those are two factors that are kind of motivating a lot of this intrigue. Besides, I think the more important thing, and that is, there's no doubt at all, even specialized units increasingly show that ICUs, CCUs, your outcomes clearly related, survival and better outcomes in general are definitely a factor for those with more education at the basic level. Community settings absolutely will remain. There are going to be many more people as we come up with devices to keep people at home that can manage their health care through the use of nurses at differing levels to do the assessments and provide interventions and changes. Way back when, I remember when I was doing my advanced practice, the VA, one of my rotations was with the visiting Veterans Administration, and they had NPs going out to see the patients, those vets who could no longer get to the Veterans Administration clinics. They were compromised enough that they couldn't. Could be for a lot of reasons, mobility, their own physical status, lack of transportation. And so I went with my mentor, and we visited the vets on that day's list, and you were doing the things that allowed you to make changes in their treatment plans, require and ask that they have lab studies done or other studies. So it's a very viable kind of role for nurses and will not change over time. And for the elderly in this population, we need to consider how we will enrich and enhance their possibility of living well. And if that means more visits and more health care in the home, that should be done. I also advise that the placement, when required in institutions, for those with cognitive deficiencies and cognitive insults, should not continue to be left to those who are least prepared. It is a great insult. It is indeed a disgrace that those individuals' lives are being left to those who do a very fine job at trying to do it well, but without the understanding of the dynamics involved in that situation, cause great chaos for the patients and also incredible stress for those PCAs and those nursing assistants. And so I think we need to understand that the geriatric population, not the well or not the able to be cared for, but those who require institutional care or agency care, really will depend on how much joy is left in their lives by those who care for them, that understand how to give that joy. And I guess what I want to say now is advanced degrees. Now we're talking about master's level people, okay? Master's level people, advanced degrees, and this includes master's and doctoral level. We need them in the nurse educator role. And as the increases in the projections for the needed nurses in 2020, you'll see that, and the statistics that we have for how many people have applied to nursing school basic programs and haven't been admitted because of lack of faculty or facilities, you can see where the nurse educator role will continue to emerge and grow, but we need people to meet the needs of those people for preparation and education. Advanced practice roles, they will function as they do now as independent nurse practitioners, CNMs, and even CNSs, while they may not practice outside of the confines, but some of them are now in specialty areas, will continue to be a need. And as I just reconfigured what I said about care to the general population with non-specific specialty needs, you can understand how that's going to happen. But we also need advanced preparation for leadership roles, for leadership in healthcare administration and healthcare professional associations, because we need people who understand what the policies are and policies' interactions and interconnections with the political process. And that is not well done by people who don't understand the roles of the nurse at the many levels. And so that's going to be a significant area. I would like to say that 20%, in 2007 number of graduate degrees increased by 37%. And that occurred during the 2000 to 2007 timeframe. That's very significant. Geriatric population, as I already mentioned, absolutely has the most legitimate claim for advanced specialty practice. Informatics, I point this out now because that combines nursing, computer science, information technology, as well as efforts to manage and use data more effectively in healthcare, and that need will increase. This specialist uses data more effectively to support patients and medical nursing staff in better decision-making, in preparing the research and the development and the process of forms and mechanisms that will create the software and information systems that permit technology to produce optimum patient wellness. So that area, I would expect, is going to be screaming for. And I hope that those of you who are in practice at whatever level will make your claim for the people who are hiring people to understand that that is not anything but a less than urgent need. You don't need people designing systems that nurses are going to have to use who haven't ever understood or been in a situation that makes them really comprehend what is needed. I'm also just going to lastly say, in terms of the diversity of the profession, which has been a real challenge in some ways, and it also offers opportunities, regarding race, gender, and ethnicity, shows incremental changes. Men now represent 11% of the profession, and thus far seem to have a preference for the advanced practice role as certified nurse anesthetist. I think it's interesting that we are now at 11%. When we started as a program, or when we, maybe in the 25th year, we only had representation of males at maybe 2 to 3% proportion of the enrollment. Interesting. Now we're at 11. Don't get excited. That's not a really big increment. But I will also share with you some of the reasons why men didn't choose. And I find this intriguing as a history. Did you know that in the Civil War, but this is also cultural in a way, but most of the care that was provided requiring nursing implications was given by men. Now, after the Civil War, that changed. And indeed, so many changes occurred that I think it's fascinating. Men were no longer welcomed in nursing. Do you know that there were states that had actual state laws prohibiting the entrance of a man into a nursing program? The military contributed to it significantly by refusing after the Second World War, no, actually, First World War, to refuse to allow in the Army Nurse Corps men. Second World War, it was women. And then that became the only thing that was in the Army Nurse Corps. So there are lots of important, significant features of why the population of men did not rise at the level that it probably should have, considering their representation in the total population. Okay, and finally, younger cohorts in reported statistics are indicating increasingly greater proportions in gender, race, ethnicity representation. So the younger the population that is entering the profession gets, or let's put it this way, the more the older population leaves it, we are going to see improvements, and we do. The statistics prove it, in both gender, race, ethnicity, but particularly race and ethnicity. But gender is a big piece of it. So I close with the notion that I want to tell you that my appreciation for what this program, in its 50 years of existence, has done, because I think it has addressed all of those areas. I think it has done a magnificent job in the number of students we have in terms of diversity and the cultural implications. I think we work hard, or did work hard, to help these students and our faculty understand what the role of culture is in preparing a qualified nurse, and in also preparing nurses who understand the ethical implications of what it means to apply those ethics to a non-dominant culture, which requires you to understand the practices and the beliefs and the values of the other. And if you've never been an other, you need to do some reading on it. It is a very isolating experience, and it is a very lonely experience for many people. But I also think we did a good job of increasing the number of men, and I certainly think we did a good job in producing more and better educational programs to meet the needs. We now have not only a master's program, but this institution had the first doctoral program of this university, and that's incredible. So I wish you all well. I wish to thank the faculty for inviting me. It has been my great pleasure to be here, and for each and every one of you, I wish nothing but joy and goodness in your lives. Thanks so much. And this, and you all know, well, you won't all know. This is Dr. Nadine Akhtan, the director, chair of the Department of Nursing now, and she wants to say hi.
Did we have a question?
Oh, yes, yeah. I'm sorry. Oh, yes. Uh-huh.
It's 1981, and I'm a new nursing student, and I'm parked in Area 6, and I have a bad habit of being late. And I have a professor who has a command of nursing that I've never seen before.
That's you.
She lectures without a textbook, without notes, without an index card. If I'm 5 minutes late, I have to take my notes and Xerox them, because in 5 minutes late, I'm losing 6 pages of notes.
I'm so sorry. Did you improve? Did you improve your tardiness problem?
Aspects of the human body like I have never seen before. I have never, and I've gone for advanced degrees, had someone lecture and go on with not even a cue.
Thank you.
Unbelievable. And
Well, I must tell you, the reason for that was probably because I have a strong and pervasive belief that an understanding of the parts and the workings and the functioning and the interconnections between one's mind and one's body is essential if you're going to do a good job. You have no business being in the profession.
Hold the candle to you and you talk two things.
Yes.
My heart. You treat every patient like they're your family.
Absolutely.
And put yourself on the other side of those bed rails, so you never know when you may be one. And because of you, I am the confident, caring person and nurse that I am today.
Thank you, and I'm glad for you that you are the competent, caring nurse. Thank you all. Please sit down. You really need to, because I'm going to run away if you don't.
Good evening. Are there any other questions for Professor Connolly? I know we could talk here all day and about all the wonderful things that she's done for us all, myself included. But again, I'm Dr. Akhtan. I'm currently serving as chair of the nursing department, and I have the distinct honor to present my mentor, colleague, and friend, Kathleen Connolly, with this certificate of appreciation from the Department of Nursing on her ongoing, see, even if you retire, we still come find you, dedication to the department and this informative and interesting perspective of nursing today. Thank you, Professor Connolly. The couple of housekeeping things that they keep giving me papers that I have to tell you. Please be sure that you've completed your pre-test and your post-test, and you can pick up your CEU contact hours of 1.5 hours on the way out. And I'm most hopeful that you all can join us for light refreshments, a tour, and we have some fun activities scheduled as we show off our new state-of-the-art nursing building, University Hall. So I welcome you to all join us, and if you don't know where it is, you can follow the group. It's just a short walk away. Thank you for coming. Good job.